Welcome to The Explainer. In this session, we're tackling a condition that can take a simple, minor injury and turn it into a life-altering ordeal: complex regional pain syndrome. So, let's just start with two questions that really get to the heart of this. First, why can something like a minor wrist fracture lead to months and months of unrelenting, completely disproportionate pain? And second, what if the key to managing all of this has less to do with the limb itself and everything to do with actually rewiring the brain's perception of it? All right, so the insights we're covering today come from a fantastic 2025 narrative review titled Comprehensive Mechanisms and Non-Invasive Treatment for Complex Regional Pain Syndrome, which was published in the Journal of Pain Research. And as always, the links to the full bibliography are waiting for you in the description below. Okay, let's jump right in. We're going to start with the CRPS conundrum itself, the real clinical challenge of simply identifying this condition in the first place.
So what are we really talking about here? Well, picture this. A patient comes to you with a minor ankle sprain. You expect it to heal, right? But instead, their foot becomes this source of just excruciating, burning pain. It's swollen, it's changing color, and it is so sensitive that even the light touch of a bed sheet is absolute agony. That right there is the clinical reality of CRPS.
So how do we actually diagnose this with any certainty? Well, that's where the Budapest criteria come in. Think of these as our clinical anchor. You can see the four categories right here: sensory, vasomotor, edema/pseudomotor, which is all about swelling and sweat gland activity, and motor/trophic, covering changes to the skin, hair, and nails. Now here's the key. For a diagnosis, your patient needs to report at least one symptom in 3 of these 4 categories, and you need to observe at least one clinical sign in 2 of them. It's this structure that allows us to make the call confidently.
Okay, so we know how to spot it, but what's actually driving this perplexing syndrome? Let's peel back the layers and take a look at the mechanisms that are firing away underneath the surface.
You know, the thing about CRPS is it isn't just one single thing going wrong. It's more like a perfect storm of 3 interconnected processes, all feeding off each other in this vicious cycle of pain and dysfunction. We're talking about a fire starting out in the periphery, an alarm system going haywire in the spinal cord, and a completely corrupted map up in the brain.
It all kicks off right at the site of the injury. The body's immune response just goes into complete overdrive, unleashing this cytokine storm that basically floods the local nerve endings and makes them ridiculously sensitive. This is what lights the match, It ignites that fire in the peripheral nerves and drops their activation threshold way, way down.
So, this constant barrage of pain signals starts screaming up to the spinal cord, which then becomes hyper-excitable. The metaphor here is perfect. It's like a faulty fire alarm that is just stuck in the on position. So now, every single incoming signal, even the lightest touch, gets amplified into this deafening roar of pain.
And this is where things get really wild. The brain itself starts to rewire, but in a very bad way. The cortical map, the brain's internal blueprint of that affected limb, it gets all smudged and distorted. The best analogy is a corrupted computer file. And this is what leads to that profound sensory confusion, the motor problems, and sometimes that bizarre feeling patients describe, where the limb just doesn't feel like their own anymore.
So, if we understand these mechanisms, the logical next question is, how do we target them with medication? Let's take a look at the pharmacological tools we have in our arsenal.
Now this is so important because it represents a huge shift in our thinking. We're moving away from just chasing symptoms and moving toward targeting the actual root causes. What you're seeing here is essentially a map, connecting different drug classes directly to the pathophysiology we've just been talking about. And this allows us to be so much more precise and so much more effective.
And when you dig into the evidence, a couple of things really stand out. Now, a lot of different drugs are used, but the meta-analyses consistently point to 2 key agents with the best evidence for efficacy and safety. First, we have bisphosphonates. They help to quell that local immune response and the acidic environment it creates. And second, we've got ketamine, a potent NMDA receptor antagonist that goes right after that central sensitization. It's like it finds the off switch for that stuck alarm.
But listen, medication is only one piece of the puzzle. It is absolutely crucial that we also address that corrupted file that's up in the brain. And that's where targeted rehabilitation comes into play.
A really powerful tool for this is graded motor imagery, or GMI. It's this fascinating therapy that's all about rebooting the brain's map of the affected limb. It's a stepwise, 3-stage process. You start simple with things like left-right discrimination exercises. Then you progress to imagining movements without actually doing them. And finally, you bring in mirror therapy, which kind of tricks the brain into restoring a normal body schema.
And we can't forget the fear factor. Kinesiophobia, the fear of movement, is a huge barrier for these patients. That's where pain exposure physical therapy, or PEPT, is so valuable. It's designed specifically to help patients break through those pain avoidance behaviors that keep them trapped, and the results are just remarkable. PEPT isn't just safe. We're seeing functional improvement in 90% of patients and significant pain reduction in over 70%. Those are huge numbers.
Okay, that was a lot of information. So how do we put all of this together into a practical, actionable plan that you can actually use in your clinic with your patients?
Here are the 3 key clinical takeaways. Number 1, diagnose early and diagnose confidently using the Budapest criteria. Number 2, treat the mechanism, not just the pain, with evidence-based meds like bisphosphonates and ketamine. And number 3, rehabilitate the brain. We have to implement these powerful techniques like GMI and PEPT.
And to make all of this even easier to remember and to share with your colleagues, we've come up with a simple mnemonic: FIRE.
F is for find it early with the Budapest criteria. I is for intervene with mechanism-based drugs. R is for rewire the brain with those cortically directed therapies. And E is for empower the patient through a comprehensive multidisciplinary approach. That's FIRE.
So here is the call to action. The very next time you encounter a patient with post-injury pain that just doesn't add up, don't just see a painful limb, see an opportunity to apply the FIRE protocol and fundamentally change the course of that person's life. You have the tools to make a real difference.
That's all for this explainer. Disclaimer and bibliography are in the description.